Quality and Compliance Committee meeting at 3 o'clock on September 25th. Rita, can you record roll call, please? Okay, great. Can I have an approval of the agenda?
Move to approve the agenda.
You? Don't see any public participation in the room. Is there any public participation online? Okay, no public participation. We will move to the approval of the minutes from the May 22nd meeting.
I read the minutes. I move to approve the minutes.
Second. Thank you, guys. All right, we will move on to old business. First is the board quality dashboards. Nope. That's what she's got there. Nope.
It's going to be that. It's going to be right above that.
It's gonna be where?
It's says Q1, Q3 2025 quality main dashboard, Q1 on the left-hand column.
Yeah, she didn't like it though.
There it is.
Okay.
Okay, I'm Robert from Quality, and hopefully you guys hear me okay. I'm going to present our main quality dashboard. Now, most of you have seen this before, but just as a quick refresher, we've chosen several quality metrics and arranged them by the pillars that you see there on the leftmost column. Most of this data is updated quarterly, so what we're going to be reviewing today is second quarter 2025. And you can see also the rightmost column indicates how we're doing in each category. So I'll just go through here and summarize quickly. Accreditation and certification, we remain ready. So our accreditation and certification status remains at a yes. Infection control, catheter-related, so we're exceeding goal. The readmissions and the quality ratings, our 30-day readmissions, we're about at half of what our previous benchmarks were, which is good. 7.8 in first quarter of 2025, 8.9 in the second quarter versus about 15% for last year. The hospital compare and the CMS star rating, it's a true leap from 4 to 5 stars, and we're meeting the gold standard there. We will be adding some leapfrog data to this dashboard in the near term. Sepsis management for the CMS's SEP1 measure. So first quarter, we were at 52%, which is just shy of our goal of 55%. But then we had an increase to 63% in the second quarter, which was solidly above our target. And I will say that as of today, now this could change as all the cases are not yet in, but as of today, for the third quarter, we're about 69%. So that's so we're maintaining and exceeding second quarter performance, although that isn't a final number yet. The patient safety, falls, and behavioral health. So falls with 0 injury, 0 in both the first and the second quarter. So we're on par with our benchmark there. Without injury, we have a slight gain there from 2.7 to 2.68 per 1,000 days. And that's also within the goal. I don't know if we lost the spreadsheet or not.
Sorry, Robert, we just had the wrong packet up there. I needed to pull the right one up.
You can keep talking while we're getting it.
Yeah, sure. Sorry about that. So I think we're on restraints. So we're a little bit over the national there at 0.34 in quarter one, 0 in quarter two. Seclusions we held at 0 for both quarters. Surgical site infections, 0.2 in quarter one, 0 in the second quarter. So we remain below that 0.3 per 100 patient threshold there. The CAUTI and C. diff infections, 0 occurrences there, sustaining the goal. Hand hygiene compliance slipped from 93 in quarter one to 79% in the second quarter. So that's dropping a little bit below the 88% target. And I know Charlie's working on that. The safety culture and employee engagement, as well as the physician engagement indices here. This is all 2024 data, and these surveys are slated to go out again very soon. So those will be updated. Patient experience, HCAHPS, we're 80% in quarter one, 81 in quarter two. So we're holding just shy of our 85% percentile goal there. Likelihood to recommend, we're staying above 80%, which is well past our 69% goal there. A few operational metrics. We have ED length of stay, 148 minutes in the first quarter, 171 in the second quarter, which is in excess of the 125-minute target. The OR utilization and on-time starts, this data is under review. We're going back and making sure that that's accurate, so you can ignore that for the time being. As far as engagement and documentation toward the end there, we have Patient Family Engagement Council. I believe this indicates we hit 40% advisor diversity, which is above our 30% goal. And the CDI carried forward rate improved from 84% to 96% in the second quarter. And that's all I had for the main dashboard report. Did anybody have any questions?
I have a question.
Yes.
So the trend column that you presented is not the same as the one I have in my packet. Is that because the one that was on the screen was the wrong one? Or?
Yeah, we have the wrong one there to start. Sorry, Al.
Okay. All right. Well, that answers my question. Thank you.
Any other questions? Okay, next section. Okay, I'm taking it from here. So workplace safety, this is what we're at. We started measuring this in 2024. So that was our baseline year. So we can start measuring our trends based on our 2024 data. As you can see, quarter one, we do have some increases in 2020, or excuse me, quarter two in 2025. Emergency services, that's our emergency room. We had some increases, a lot of it due to our volumes and related to mostly our behavioral health patients coming in our emergency room. And we also had a uptick on professional conduct. This is behaviors that we had an uptick on. And the other issue we've had in quarter two was JPD called to campus. Most of those are related to emergency room visits. So any questions on that?
I have a question.
Mm-hmm.
Is the professional conduct the hospital staff or the medical staff?
It's both of those.
Self-reported or report by other staff?
It could be reports of staff, or it could be anonymous reports also.
Oh, okay.
Mhm.
So,
Yeah.
thank you.
And so with the uptick in emergency services, we kind of had a lull there. We have the uptick. I think the biggest reason we're having an uptick on it is I think staff have seen two things. That management is addressing them and taking it. And so that's why you're seeing a lot more reports on it. And it's our security services are doing a lot more reporting. That's where we're seeing the bulk of our reporting. We have a full security force and they're doing a lot more of reporting. Great, we're just good. Yeah, I want to see more reporting. Reporting is good.
You have there that JPD's been called to campus. Is this, is it threats of violence? Is it, are you seeing increases of people? Why are they being called?
Because we're taking actions seriously. So if a patient is overly aggressive or assaultive, we're empowering our staff, our security to call JPD. Because if we cannot take care of a person, and we need to make sure they're going to the right place.
Oh, my question, I'm sorry, is it towards staff that these behaviors are happening, or is it also towards family members?
A lot of it is a patient comes in and they're being aggressive towards staff. Okay. And then we're making sure they're medically stable and then going to the place that is going to be best suited for them. Thank you. So do you anticipate, I'm sorry, no.
This is just kind of a policy question with regard to safety and the use of the security staff. What is the policy? Is it observe and report, step in, take down for our security staff? I mean, because there's levels of intervention that an organization can allow.
So first, if any of our staff, we first try to de-escalate. We talk, try to figure out why the person is escalating. You try to talk down, meet their needs. If that's not being able to be handled by the first person that comes in contact, then it's phone a friend, get another clinical person to come. If that's not effective, then you call security staff to show a concern. So you have a group of staff, including security, to show a concern. If that's not able and the situation is deemed that the person is going to either harm themselves, it's being a threatening environment to our other patients around, then we may have to call JPD into campus. That is our last thing that we do. If we can put hands on a person or use, in our emergency room, we do have a seclusion room, we will use that. If it's safe for our staff to do it. If it's not safe for our staff, then we do call JPD. As you can see, there's 9 incidences that we've had to have on our campus, but our security officers and our teams are trained each year. They go through training to be able to safely put hands on. We never do that, in a single situation. We always use a team to put hands on safely for the patient because we don't want to harm ourselves or the patient.
Thank you for that, that progression. I just hadn't gone through it before.
Yeah. If it is a visitor or someone else that's not a patient, our response is to have them leave our facility. Our response is to have them get out of our facility and then lock the door and then call JPD and say there's someone out on our campus. We're not going to put hands on someone who's not our patient. Our goal is to get them out of our facility and then lock our facility. Thank you. You're welcome. Any other questions? Okay, medication dashboard. All right. All right, so trends again that we're seeing. Again, you see some upticks. A little bit of our upticks are volumes also. So just remember, like our emergency room, our
volumes have gone up in the summer, so I see some upticks of things that are happening. So there is a little bit of uptick happening in our emergency room, so don't feel too alarmed in that just because of our summer volumes. Some of the things that we are seeing that we are working on with, we have a new an interim director of pharmacy, which I'm very happy, just started this week. So we're going to be working on some of our medication practices with our pharmacy team, because they've been short-staffed, are looking at our wrong doses. Those were some things that are a little bit looking at the amount of medications are. So those were some of the trends that we're going to be working on with our pharmacy. The other trends that we're looking at is our surgical services. Some of our medication errors that are happening there are a lot of not so much wrong dose, but our documentation errors with our anesthesiology systems and the way they're managing their drugs with anesthesia and documenting through to their practices there. So I'm hoping that with monitoring that a little bit closer, those are starting to come down, but will continue to come down. So we're making some progress from Q1 to Q2 on those. Other things that we are working on closely is changing at Wildflower Court. We've had a couple hiccups with our processes with our contract pharmacy over at Wildflower Court on drug administration over there. So that's another area that we're looking at with some of our drugs coming in with our wrong doses, and those don't reach the patient, but they are documented on this form as wrong doses, but they don't reach the patient. So, but they come from the contract pharmacy as wrong dose. So they're not reaching the patient, they come out as catches. The other thing that is a good news, because Joe always says, do you have good news for me? I look at our scan rates are still high, even though I can't really say it's green. I still look at high rates of scan rates. And Rhonda has been working with a scan medication team. And the best thing we can do for patient safety with medication is making sure we're scanning our patient and scanning our meds before we administer them. And I will say our emergency room has been really working very hard on that. When we started with Meditech, their scan rates for their medications and their patients was almost non-existent. And now they are in the high 90s. So that is really kudos to their den moms down there and working on their scan rates of it. So that is the highlight of this dashboard.
So obviously the pharmacy is significantly higher. And have there been events that reached patients in that 45 number? A lot of what they're catching, and I think the hardest thing that they are catching is their expired meds and filling their Omnicells, because they do not have enough of their assistants for their pharmacists. So their support staff, they're extremely low, and their med reconciliation teams. So that's what they are catching and reporting on. And that's their biggest reporting. So no events reaching patients. No, what they're doing is they're catching expired medications and that. And so we really need to beef up their clerks and that, because they do a lot of self-reporting on things that don't reach the patients, but they're really short on their staff. They need a lot of extra support.
I would say if it does reach a patient, that's the dashboard you get during the board meetings, during the executive session. So you've been told about those.
Mm-hmm. Yeah.
And I'm looking at Chad when I'm saying that, and I'm like, get those people in. It's your fault?
I thought you were playing with Chad.
No, I want them to work hard. Okay, any other questions? Great, lab dashboard. We had a ton of green on this. Unfortunately, we had, and they've been doing great with their blood cultures. We had an uptick on, a couple of blood cultures from our ED, so, but I want to say they've been doing fantastic. So unfortunately, we had a uptick on some contaminated blood cultures, but we had almost 3 months of fantastic, but I want to say the teams have been really, really good.
In August, typically, we had a ton of admissions, a lot of patients in-house, different from July and September.
Yeah. All right.
It's a blip. It's a blip,
It's a
okay.
blip. It'll be all green next month. Any questions? Okay, moving on to the grievance report.
So there's a total of 22 grievances. They're all a different variety of grievance. ED had the majority of them. I don't know if that's due to the high volume of traffic through the ED. We have been able to research and communicate with the teams to do just-in-time training or meet with the patient to mitigate issues firsthand. One thing we are going to work on is how we catalog personal property coming into the hospital. We've had a few oopsies where we could have done a better job. So we're looking at policy for that. Going to do some performance improvement in that area. But overall, not too bad for 22, considering it's almost October. And one thing I would like to highlight next time is we need to also present the kudos that come in, which is not part of this year.
So I see one case that isn't closed out, 4-8.
Which one is that? Oh, that case is closed out. I talked to the guy on the phone. I just didn't send a follow-up letter. He was here. Gail talked to him. I talked to him. Okay, I don't know.
We're not sure where he's a person we weren't sure where he lived at the time to send his letter to. We've talked to him many times. Many times.
From Wildfire that didn't make it on here. But we'll update. So
Any questions?
I'm a little puzzled by the one about the gender. I think that might have been the first one. What was the nature of that complaint anyway?
Oh, I can talk to that one. The person, there's certain questions, CMS, at the time, well, still that want you to ask, when you're being registered. They want, and the person didn't like having to be asked those questions. So they wanted, the question basically wanted you to know, what your sex at birth was. So, and they were offended by that question.
Okay.
And they didn't think they should be asked it. And it's a requirement that we have to have. And it's basically when some of the lab tests that are sent out, they need to, know what your sex at birth is, because it's, important.
Changes the value of the lab.
Did that explanation settle the person all or make it worse or?
When they were trying to explain it, when they were being registered, it just made them more offended. So then
came up the chain to me. And then as I'm trying to explain, that, I don't know if they liked it at the end, but, I had to put in what, the standards are in their letter and sent it to them.
Even diagnostic imaging, it's important for them to know, like for radiation doses. Like they have a computerized program that figures it out, but they kind of need to know if there's like some extra organs in there, So it really does matter, yeah.
Not every grievance, the person is gonna be resolved.
Oh, sure.
Any question I should ask you about your gender? You can refuse to report. Do we allow that? I mean, is it something that we can allow not reported?
Yeah.
We don't turn them away because they're not. Thanks.
I mean, it may affect the results in care.
Get that.
Any other questions? Compliance report.
Okay, this is our standard elements that we report for Q1 and Q2. Nothing pretty much is out of whack here on it. So exclusion screenings, these compliance investigations, these are, when we look at compliance investigations, these are the issues that come up in my occurrence reporting system that are different than grievances. These are things that come up that there are issues on, like HIPAA, like if someone says someone, is leaving unsecured patient records, there's HIPAA, there's security, confidentiality, those are the type of issues that are coming through those type of investigations. If there was hotline calls, were those type of concerns. So those are the type of things that came up. The one big, one of the numbers kind of ticked up in, the big thing that came up in this quarter is we had a area that found a lot of unsecured patient records from actually a lot of what it was physicians were using patient records and then leaving them unsecured from actually, there was about 32 records left out in a physician area that were unsecured for a long time that were reported. It was about 32 different patient records. And I think they're using it for their documentation and that. And then,
Dictating and then leaving.
leaving them out and not shredding them. So, yeah, oops. So they had to change that up on it in their surgery area. So, so that was the big change. So that was a big area in that. Departmental monitoring and auditing. This, Shelley, I know you talked about this, and this comes from Tammy. So I might have to come back to this. If you go up to the bottom, Anita, the next page. I may have to get back because Tammy is out of town on when they do their internal monitoring of their claims. They sometimes find errors and then they self-report and pay back claims. So I can get you the exact numbers from Tammy when she's back in town on this.
Okay.
So that's usually what happens is when they're doing their internal monitoring, if they find errors in that, they self-report and pay it back. So I can get you the exact information from Tammy on this. And she provides these numbers to me.
And so I was curious about those and the government audits, if there was a theme of why there was repayment.
I will get it from Tammy. She's usually at this meeting, but she's off right now, so I will find out
Thank you.
what that was.
Any other questions from anybody on the compliance? We don't know that.
I saw it. I don't remember it off the top of my head. Tammy would have it.
Okay, yeah, that's fine. And is that, I don't know if you know, is that typically the percentage of outside audits that you guys get in a quarter? Between 7 and 15?
I know that what came through was normal and
Okay,
standard. So
yeah,
shouldn't be.
right.
It's about what I've been seeing in the last couple of years.
Any other questions? Hey.
And then,
Is that- Okay. Okay, all right, moving on to the facility assessment for wildflower coverage.
Yeah, good afternoon, everyone. Happy to be here today. We're going to be learning together. This program was this facility assessment is completed through an online platform, formerly known as Abacus, and to nobody's surprise, purchased by HealthStream, which we seem to have quite a few platforms we have now. So it's now called HealthStream's Quality Manager. And right before I started at Bartlett, more than 7 years ago, Wildflower Courtney purchased this because I noticed my initial sign-on was back in January of the year I started here, 2018. So anyway, so I didn't have a lot of work in it prior to Wildflower Court that first time. But just getting back into it now, and I've really picked it up this summer. It's quite in-depth. It's a full quality program. So it's not just facility assessment. It's not just the coffee plan. And I just wanted to give you this quick update on the platform before I talk about the assessment, just so you kind of know what goes in. But as a facility, we can put our process improvement projects into it where there's the opportunity to like do full documentation, updates, staff members that it can go to because everyone's email is in the system. So it's a really thorough program, I think. We can even do our coffee notes in it, which we haven't even started doing it. There's some mock practice things you can do in there as well. Also connected to survey where we can investigate something from the surveyor's perspective just by plugging information in about what's going on, so we can see the areas that we really need to focus on. So, so back to the assessment. So, Tilly had asked me at the beginning, like, did you put all this data in? Like, is it just all put in manually? In what you can do once you put in the initial data, you can actually copy to the new year, and that will bring over all of the stand data that you put in to the into the assessment. But I had decided I had done a couple of runs earlier this summer, and I ended up creating a brand new one because every year CMS, I shouldn't say every year, but oftentimes they will update language they want to see in the assessment, and HealthStream updates the language in the new assessments. And so what I did was, so it's kind of like a template. So what I did was I started a brand new one, and then I just inputted the rest of the data based on information that from previous years, and then also anything that's new this year for the facility. So as far as the resident patient data, a lot of this, we'll see a lot of resident level, or not resident level, but various diagnoses, age, that kind of stuff. That is actually uploaded into the platform from our from the data sheets that we send to the government, to Medicare, Medicaid for payment. So we're required to send data, well, even for private state patients, private paid patients, we're required to send data to the government about the state, like diagnosis, age, all that kind of stuff. And we take that data and we copy it up into this platform. So it does all the calculations for all of our residents. So you'll see a lot of information about support, how much support people need. And we'll just, I'll explain it as we go along, but a lot of that has been uploaded as a document. Let's just say one of the reasons I started this over the summer was because I was working on the new assessment, and the MDS nurse had told me she needed to upload recent MDS, and it turned out, that's what we call those data sheets we sent to the government on a quarterly basis, and there was quite a few that needed to be uploaded from this last year. So it is something that is going to be uploaded regularly to keep this updated. So as Anita's scrolling through, you can see kind of the activities of daily living here. This is essentially fiscal year 2025 that we're looking at. And I just ran fiscal year for the hospital, right? So from last July 1 until June 30th. Yeah, go ahead.
A question about the column that has low, very low, high.
Oh, yes.
What is good if it is,
So,
I mean,
so it's not necessarily like a good or bad, right?
Right.
It's kind of like just showing us what our who we're caring for, right? This is describing our population at Wildflower Court for the last year or for the fiscal year, which, by the way, maybe talk to calendar fiscal. I don't know. I'm so used to this, but anyway, this is just describing who was admitted, stayed at Wildflower Court over the last fiscal year. So, like for example, here. Anita, can you, let's see a good example. Can you scroll down just a little bit? There you go. So for example, okay, so activity of daily living. So assistance required, maximum assistant of 2 persons or more. You can see here that for transfer for 2 person or more, we actually had very low. It tells you the admission numbers, which it's kind of, this is a PDF printout, so it's not really clear because you have to kind of know what's the beginning. But that first column is admissions and stays, and the second column is days versus, right? And so it just shows you that compared to, and this is a national benchmark. Yeah, it's a national because these are all of our national data that we're submitting up to. Excuse me, it's the Medicare and Medicaid numbers that we're submitting to the government, right? And so this is kind of a pool of that. So this is at that level. So you can see for a facility that we're very low on how many 2+ people for transfer that we have in the facility. Of course, I'm sure we're grouped. It doesn't talk about our needs. We are 61 bed versus 100 bed. So, yeah.
If I may, it's just a snapshot. Clearly, we're not a rehab facility because patients don't come in and go out. You start that number very low. They come in, they stay, they die. And so,
You can see, yeah.
and so we're a nursing home, and it's reflected in this data. You just
Totally,
check.
yeah.
We don't have a lot of Alzheimer's patients. We're not a, whatever those
Memory
care places.
Yeah, right.
We are a nursing home. It is reflected in the data. I am this, the low and that.
and so what I was curious about in the benchmarks was very, like on, what is it, eating? It's very, our percentage is very high. So I was trying to figure out what's the.
So I will tell you, if you scroll to the upper one, it says 1+ person per assistance, and we are very high for support with feeding. If you scroll down a little bit, Anita, and we're very high in that category for support. We're just high. But this one, it's funny that you brought this one up. All the ones that you would bring up, I circled it because I'm like, heck, 2+ person assist for feeding. I was trying to figure out what that was. So I'm gonna have to look into that. And if you guys see anything, if you have questions, I'm actually might have to borrow for Pendio, but I need to write these down because I am learning this stuff and I can't wait till I know this like the back of my hand. So
Make people are on 2 feedings.
so right now, at least 4, 5, 4.
That might bump it up.
Well, I was wondering if that would be it, but it's not really 2 person.
Yeah.
But anyway, so, and before we scroll anymore, and again, this can be an initial, I'm hoping to get invited back to board quality, maybe more than once a year, because I feel like there's a lot I want to just talk about, because we can do this and we'll get to this piece with the coffee and we'll get to the coffee plan eventually, just understanding the board's responsibility for the whole quality program at Wildflower Court, and the policies. I feel like other things too, because I just want to be able to share with you kind of what you need to know, right? So one more thing before we begin on the assessment, I'm not going to read through everything. I will answer questions as much as I can. But so the facility assessment, it has 4 major parts. We've got the resident population profile. So we talked about that a little bit, the needs of our residents, kind of who populates the facility. The second piece is staffing, training, services, and personnel of the facility. And the third section is the physical environment, technology, and equipment. And then the fourth section is all hazards risk assessment. And then they have a bit at the end for assessment contributions and for supporting documents. So each of these sections have 4 pieces under it to do with function, mobility, physical disabilities. The second piece is acuity, diseases, conditions, and treatments. The third piece is cognitive, mental, and behavioral status. And then the fourth piece is cultural, ethnic, and religious factors. So what they're doing is they're taking kind of each of the sections, and we're needing to talk about like these 4 pieces under it, like how as a facility we kind of direct our care and to support the residents where they're at. So I think it's laid out really nicely. Maybe sometime I could, just to make it clear, I can just take one little section, we can break it up to a little bit more closely. Because I mean, I had to print mine out to just be able to keep capturing kind of what I was reading. So, so again, all the data you're seeing is things that have been pulled from the actual data we submit. And see, there were a few pieces I just wanted to talk about. And I'm glad, Dr. Esther, thank you for bringing that up. It's really true. When you read this, I'm like, when I see very high or low, I mean, I think it was at the deaths in a year. I'm like, well, that makes a lot of sense. I mean, we're a nursing home and, you know, maybe some years more than others. That was my note on the 2% viewing. What the heck is that? A couple of things that stood out to me, Anita, on, oh, I didn't write the slide number. Scroll down to A1. Right there. Yeah, stop right there, please. Thing I'm going to look into, maybe, oh, sorry, down a little bit, Anita, at the top of that page. It said here, speech language pathology and audiology services and an occupational therapy. I noticed those were low and very low. I'm going to look into this because I'm wondering if this is something that we could maybe potentially move up a little bit. Like there's opportunity here for us, right? Where we can do more with speech, we could do more with OT services. And that is something that we could build for. So we're actually working with the therapies department right now. So there's some things in here we could adjust potentially to be positive for Wildfire Court, but anyway, more to come on that. So there's some narrative in there. I know I did copy and paste some of this large narrative from section to section, and I adjusted within, you know, the pieces, like whether it was to do with functional mobility or cultural ethnicity, ethnic pieces, or, you know, behavioral pieces, statuses. I did adjust language in it, but I kept it all the same. A lot of this is required template. So you'll see that I did copy and paste throughout the different pieces of sections, but just adjusted to what we were speaking to. It's just way too much information to read or really describe. Again, a lot of this is kind of language, and so we're just addressing it. And again, I did look at those highs and lows and compared it against, you know, what we were actually doing, right? Because this is what this is for, right? Or do we have the facility that we need, the actual physical building? Do we have the right equipment in that building to support the residents that we have? You know, we have a lot of, you know, gastric tube feeding residents. Do we have enough equipment to support them? Or, you know, do we have we have some a high number of, you know, dementia patients? Do we have the right amount of staff to care for them and to keep them safe? So, you know, it was really great to kind of start fresh with this myself and just check every box, because I was able to think about what we have right now, which is what I was looking at. And I do feel like we're doing okay in a lot of these senses. There wasn't no projects jumped out at me like, oh, we need to look at this. Because I will tell you, a lot of the stuff we've done this year, like we replaced our sidewalks, we've got a couple of new blood pressure machines that for the staff that we were missing. And we've been incorporating, and that's just the facility side of things, we've been incorporating and kind of buying new equipment as needed. And so it's just one example of for this year of what we're doing to kind of meet where this facility assessment is telling us we're at. So let me just scrolling there. I'm gonna go through my millions of pages. I did have a couple of notes.
And also looking at the type of patients or residents that you're looking at accepting. Because that goes into your plan also when you're looking at what type of residents you're pulling into your facility that meets with your community.
We were just talking about that this morning at our admissions meeting. We meet a couple of times a week for admissions, and we were discussing, well, maybe we need to have a few more beds for rehab patients. And yeah, that's exactly right. So, and the reason that we use this, I want to say MDS, but that's not spelling it out, and all I can think of is material safety data sheet.
That's what I think.
My mind is literally just gone blank. It is to do with the resident data that is submitted that we track, and every quarter we update this information. And it is part of their care plan. I mean, it's updated constantly. Anyway, it's considered evidence-based to use this data to drive any improvements or needs of the facility. So I'm very confident after kind of reading what is required for a facility assessment that we are doing it here. And I'm just grasping the picture of it, and I'm sure this will become more just back of the hand stuff for me as time goes on. Minimum data set. Oh my gosh, so easy. Minimum data set, NDS, yes. And in here, a lot of times they are using like different assessment like things and stuff to collect this data. Let me just scroll through. Then I don't know if anybody had any questions about the actual data pieces here.
Did anyone on the board have questions when you were reviewing your packet on the facility?
No.
Other than the ones just there.
I just thought it accurately reflected.
Yeah.
Yep, that makes sense. Yep,
That makes sense.
no, trach patients, okay.
So Deb worked with her whole team on this, just to let everyone know when they did the facility plan, she works with her MDS coordinator, her social worker, her director of nursing. So this is a collaboration. When she goes over there, she started to gather all the information, and then she sits with her whole team over there, and they put the facility plan together every year, and they update it every year. And then she brings it and presents it to the board. Because this is the one thing that they have to have in place every year before she brings it up to everyone. So,
So I have a question, and it's in regards to, are there any significant changes from previous year?
So I read through last year's. That was the only one I read through, and I didn't see a lot of changes I added to from this year, but it was mostly it wasn't related to staff. Well, actually, there were some staffing changes actually. As far as the care that we provide to the residents, I wouldn't say there was a lot of change. Staffing wise and equipment wise, I added to it, so there was some increase there. But as far as changes, no, we haven't really received any residents that we haven't kind of previously cared for that we've seen, a diagnosis kind of thing. So, one year they had somebody that had like a heated CPAP thing. That was a new treatment that we provided. So that was added in. And once we add something in, we don't take it out. We just leave it there because we have the capacity to care for somebody with that in the future, right? So nothing major, no. Staffing wise, yes, because we have changed up the home attendant program a little bit, where we essentially doubled back to where what it was originally intended for in the facility, with like a morning and an evening shift. And then also, of course, just, the last 9 months looking around the facility, talking to staff, what are we missing? Last week, blood pressure cuffs, we had a ton of so many manual blood pressure cuffs and sleep manometers, everything in the drawers. But realized our CNAs coming out of these classes aren't required to have manual blood pressures anymore. It's all from machine. I'm like, we're bringing in these CNAs for Jen Twaito and her group and having to teach them manual blood pressure. So things like that, just correcting.
And I think that's benefit in your report to us to have that information.
Yes.
So,
And
Thank
you know what I might do too, what I can do is just keep that in mind. My plan is, after being in this, I'm like, there is to have to take this on every year and have the team take it on and everyone sit around and be like, what did we do last year? My plan is I'm going to do like a template where I just have it continue, like as things come up, I'm just updating it. I can just create at the end of the year. Narrative and we're good to go. So I want to continually do this. And I think having the quality backgrounds really inspired me to be able to do that. Already started my next year's one. So it is best practice to also have data from the residents and family members if you can, or excuse me, not data, but inputs. And so we did add a little bit of input, like I know you've heard the director of the kitchen talking about the reindeer sausage that we've had and how it. So that had been directly from the resident council meeting at Wildflower Port and requesting some, kind of more food that was local to Alaska, and he was able to get halibut, which was amazing. So it's not every week, but really happy about that. And then also just having more local groups coming in, and like an example of what we're doing that we feel like it's really important under the cultural section is like celebrations coming up here in June on 2026. And so in the past, I remember this from back in the day, in the past, a lot, if we reach out to the groups, they will come to Wildflower Port for like the final dress rehearsal. It's been really fantastic. So things like that we can offer to the residents. So just so you know, we are staffing the facility to census, or not to census, but just to the expectation that we're going to keep the beds 57, potentially up to 61. So it talks a lot about staffing and how we're doing that, but we are just staffing all the time to the fact that we might have the beds. So we don't adjust staffing according to the census. So this is again going to be an ongoing thing I see as that we add as the year goes on, and hopefully can capture all of the great work and just everything that's going on with the facility this time next year. Got that. And then it's such a big document. I didn't print out any of the supporting documentation. HR was huge in supporting the staffing plan. I know they did a lot of work into it last year. I just read it over and made a few adjustments according to when we changed staffing, and then just brought that one over again for this year. That's again a multi-page document. The hospital's been incredibly supportive of us with our staffing. We are very well staffed compared to the rest of the nation, and walking that fine line, we don't want to overstaff, but the community, I believe, has a high standard for care at Wildflower Port, and you have to have the right amount of staffing to be able to do that. So I'm very happy. I'm very happy with the way the schedule looks. And although we still have like what 23% travel staff, we're already anticipating the next group of CNAs coming in. And we've already just in the last couple of weeks had a couple of nurses wanting to come on time. So it's going to be a slow process, but it's happening, and that's the exciting thing. We have to be patient. I have to be patient. It will happen. So
Only 18%.
is it?
Yeah.
Must have done
I think it was 23 last time,
that. Yeah. Okay.
unless it's eight with it.
I was counting all. No, I'm going to take the 18. I'm going to take the 18. Let's not oppose that. So, so unless there's any questions about facility assessment, just know I will be adding to it as the year goes on and things come up to keep it updated. Yeah, plan to keep this program. I think it's going to help from year to year. I know part of what you look at is this sustainable changes and like if people change or whatnot. The nice thing about this program is that, as long as there's some kind of basic outline and direction for it, which I kind of have to jump in. Although Emily Murley's been fantastic to support. She was in the program a few years ago. This is a good way to kind of keep that year to year and with changes. So I just want to briefly talk about the coffee plan if I can. I know I need to kind of scroll through it there. The direction, okay, the governing body is developing a culture that involves leadership input from nursing centers, nursing, and from residents, their families, and other stakeholders. So they've got it outlined here in the language, and I added and just adjusted to fit for Wildflower Port. This isn't like specifically what we're doing. This is just like where we're going, like what does quality mean to us as a facility. So you won't find anything like, oh, this is what we're working on in here. But I really love reading through this and adding to it, and it gives us purpose and direction in our quality work. And I think that it would be beneficial at some point in the future because we just started working on like I know we have A3s at the hospital. I am working on some A3s be able to present for wildflower report. But in the nursing home kind of environment, they talked about process improvement projects. So kind of the same thing, just a little bit different language. So we are working on a few right now, and hopefully I can bring that for you to kind of look at, because it's actually coming from data. Gail's been really supportive and helping us like focus in on like what the data is telling us, what we need to improve, what the data is telling us. So we're going to jump on a few of those, and hopefully I can kind of bring a report back on some things that we're actively working on and that directly affect the residents and the care that they're receiving and how safe they are in their environment. So looking forward to that. But this again is just a very broad kind of statement of like what we believe in quality. So I don't know if there's any questions related to the coffee plan.
So one thing that Robert and I have been working on is for this meeting is coming up with a wildflower court dashboard, quality dashboard. So that's our goal, is to have one of those specific for wildflower court for the board quality. So we're going to be working on that with Deb, and there will be one presented in this meeting moving forward. That's it.
That'll have those process improvements in there. So
And the quality metrics specific to long-term and subacute rehab. So you'll be able to see that on a regular basis.
great. And can I just super fast, just one little bonus piece of information? I should have just added in, but I didn't. We just opened up our resident survey for the year. I think this is just the second year that they've done it. Robert and Quality have been super supportive and updating the survey for us and helping us push that out. We already have some responses, and we have some residents our staff will support with that need it. Others, the family help out. Others, the residents are themselves. So hopefully we get a good response this year and have all the data from last year. So that's happening now. We're going to close it out on October 31st. So
Great. Thank you.
thank you so much.
Any other questions for Deb? Hey. Leaf dog.
And that's me. It should be,
Isn't the one I skipped the bridge report.
Oh, this is real simple. So I don't have any slides on it for the breach report.
I stop you. So we don't need to go into executives.
No, we do not.
Okay.
Nope.
you.
It's on our website, so it's public.
Okay.
And it will be coming off of our website on, I believe, October 7th or 15th. And we are using a company called INX, and they give me weekly reports of any that come through the, we have a company that's doing a hotline, and I have had 0 calls to the hotline. The letters went out, and I've only had one person call me directly, and I've had one person stop in my office. So we're almost through with our report.
What was the breach?
And it had to do with a email phishing that came from CBJ into our system. Yep.
I think I was one of the people.
You probably got a letter from me. Yes.
No, I didn't.
Careful, what's I do?
Yeah.
I got it done to me.
Yes. Yeah. Yeah. It was a email that came up, and it yeah. I think it was 186. Yeah.
That's unfortunate.
186 responded.
186 potential patients.
Were compromised. It was limited.
Yeah, very limited.
Potentially class. We
Yeah.
can't mistake that they were, there was just opportunity.
Yep, yep.
I can't even win a cup
Yeah.
of coffee, but I can win.
Yeah. It had a potential of, very limited time, scope of time. That it could have potentially happened, so.
Now let's do leaks.
Yeah. Hi, thank you for having me on this. Leapfrog on hospital safety grade, this is the initiative that we ended up signing up for. It's voluntary. We ended up signing up for it in May, and we got access to the Leapfrog platform in June. And the first deadline was for June 30th. So at the very top, Anita, at the top slide, and it's actually a very patient safety focused nonprofit organization that actually has evidence-based patient safety aspects through John Hopkins Foundation and other national experts on their leapfrog board. And they come up with measures that go from the very top, the board, all the way down to like registration and billing, patients' rights. It covers like a very broad range of things. And there's actually two components to it. One is the hospital survey that looks at almost everything. And then there's a safety grade that they assign hospitals that is publicly reported. And that's based on 19 out of the 22 components. And it's kind of like, you don't have to voluntarily do the hospital survey to get a hospital grade. So we're currently a C. Pretty much Providence and Anchorage is a C. Fairbanks is a D. And you got Matsu, which is an A, and the only one in the state of. So, and that's kind of like what our baseline is. So our first deadline to try to like voluntarily submit all this patient safety information was for June 30th. So we had like a little under 4 weeks, kind of like try to see where we were and what we kind of like needed to work on. As you see, the patient's rights and ethics, that's where billing, informed consents would be the registration process. Preventing patient harm, that is where some of the National Quality Foundation safety aspects would be. And that also goes with the board, patient care, senior leadership, safety culture, aspects of the processes behind the hospital. They have a critical care section where they're looking to see if there's any critical care certified intensivists taking care of our critical care patients. Hospital-acquired infections, they gather the data that Charlie puts in. The maternity section is very broad. They're looking at episiotomies, high-risk OB cases, C-section data. Medication safety is another big category in this, and it's actually like 16% of the whole hospital grades. And that deals with medication administration process, computerized physician ordering, and then medication reconciliation process. They also want to know about pediatric versus adult surgeries. They want to know if we're doing safe surgery timeouts. They want to know, are we doing enough procedures to be competent in some of these procedures that we do? And then the outpatient surgery is looking at, like, do we do the medication reconciliation for outpatient surgery patients, and actually what kind of outpatient surgery procedures do we do? So by the end of November, we have a chance to keep adding to our data and our performance measures, and we can keep adding things that might raise our grade. So I actually would like to shoot for an A. I'll settle for a B, but I'm gonna go for an A.
I settle for B.
And so right now, the final, what our grade is from the June submission, we're still showing up as a C, but that data is actually not published yet until like probably like next week. So it'd be interesting to see what kind of grade we get just from the little bit of data that I was able to enter over that 4-week period. Some of the things we're working on that we're actually going to be able to accomplish is for registration, they want to know about preferred language. we only ask, what is your preferred medical language? We don't break it down into spoken versus written. We're gonna add that to our registration process. So that will be a checkbox that we'll be able to check off. We're adding to the informed consent. We're gonna add like a section for interpreter services used for those patients that need interpretation services. Right now, we don't keep track of that. You know, so we can have someone sign a consent that's in English and they don't speak much English at all. And we don't have any record of, like, did we actually use an interpreter service for that actual consent, informed consent process?
Guess what grade level your informed consent form needs to be written at?
First grade? First grade,
Yeah.
sixth grade. And ours actually was like 12th grade. We thought it was like 8th or 9th grade, but when I ran it through two literacy programs, they both came back like 12th grade. So we have some work to do.
Try to get it down to a sixth grade level is very difficult.
And part of the informed consent for Leapfrog is that they want to make sure that people are doing the informed consent process correctly. And are the patients like expected, kind of like verbalized in their words, the understanding of what the consent is actually for, what their surgery and procedure is actually for. So it actually is a good thing. The maternity section, the DVT prophylaxis on all the C-section cases, I wasn't able to add that data, but I have that data now. So that will be another checkbox that will bump up our score. The nursing workforce, what is the percentage of RNs to LPNs to unit clerks to like CNAs? And what percentage of our workforce are BSN prepared? Chad and Rick got me that data. I didn't have that data in that 4-week period because it took a lot to gather that. I have it now, so that's another checkbox that we'll be able to check. The safe surgery timeout audits. They needed 15 for the hips and knees, and then 15 for the other procedures. Surgery just finished that up like this week. So they should be getting that data to me in the next couple of days. And I should be able to enter that, and that will be like a checkbox in 2 different categories, the outpatient and then the major surgeries. The other, yeah,
To the section on the qualifications of the nursing staff, this bit of the nursing. Is that something that we can collect and integrate in our new UKG system so we don't have the delay in the
Yeah.
request?
Yeah, we just never collected, I think.
And to the chair, one of the challenges in getting that data was someone might have been hired 15 years ago and had an associate's degree and went on to get their bachelor's, and that wasn't collected. So, we ran different reports at different places and then ultimately had to, go to staff and be like, hey, let's verify. And so all that information is being put in the system.
So can there be like an annual process for folks to take a look at their record?
Since the periods are like up until like June 30th, so next year, next spring, when we enter our data, we'll be looking at a different time periods. So
What she's asking is, can the people look at UKG to validate
Yeah.
this stuff? Yeah.
Yes, that's what I'm asking.
Yeah.
That it gets validated regularly, whatever the cadence is for that validation. So that,
To the chair, it does have the ability to self-service. So they'll be able to look in there and see highest level of education, et cetera, et cetera. And that could be MD, DO, that could be BSN. So the way we've broken it down right now is doctoral degree, master's degree, bachelor's degree, and then field of study. It's that way, it could be a master's in, then listing out every single combination. So that will be good.
thank you. And UKG will actually help us do something else too. For the not this current performance evaluation, but the one in the further, next year. It's actually gonna be customizable for what the templates are. And Leapfrog would like to see on senior leadership's, evaluation, something specifically about patient safety, you know, on their performance evaluation, contributing to patient safety. But, you know, it's also,
It's been.
so that's something that is customizable that we can do, and then that would be another checkbox that we could check.
Almost done.
And then, the major areas for opportunities, as I said, the medication, chapter is really like a pretty extensive chapter, and it is 3 different parts. The one part, I really have to thank Dr. McKinney, Brett Waters and Lab, and Charity and PAS. And it was a computerized physician order entry test, and it's a time test. It's a 6-hour time test on false patients, and they give you specific orders that you have to enter, and they give you specific lab that you have to enter, and they give you a specific diagnosis that you have to enter. And then you do this time test. And as you're doing the computerized order entry, as Dr. McKinney is doing the order entries, he's taking note of different alerts that he's getting. You know, and then the different alerts should be associated with like, say potassium. You're giving potassium to a patient that already has a potassium of 6.6. And the computer order entry system that we have allows us to enter 80 milliliter equivalents of potassium to that patient that is an end-stage renal failure that has like a high potassium. So it should have like, our system, it'd be nice if we had an alert that would prevent that type of like med error. We ended up having 3 potentially fatal med errors entered during this time test. So we do have some work to do on our system. The other thing as far as pharmacy and medication is the medication reconciliation. And they want, they call it a gold standard medication reconciliation. And it's actually like a 2-page data collection of comparing the medication that they have at home to what is ordered on admission to what is ordered at discharge. And we were not able to complete that because of short staffing in pharmacy. So we're looking into using Tegria, the pharmacy consulting service, to kind of like help us do that, to get it done by November so that we can actually add to that category. We're working on revamping the hand hygiene program, and that should be like probably next year. And then we're actually, another area that we're going to work on that next year we should be able to meet is the minimum cases. They want 50 cases each for hips and knees. We do not meet that right now. And they want each physician to kind of like, for like, to do 25 would be like a good practice. 25 for each physician to do like 25 hips, 25 knees. Right now we have no doctors that are making that.
So we didn't meet it when you measured it the first time. Do you think we'll meet it by the end of the year?
No, because the end of the year period that you have to use is from July 1st, 24 to June 30th. And I just got the numbers last week, and we did not make it. We had 51 hips, so we actually made it in the hip category, or 51 knees. We made it in the knee category, but not in the hip category, and none of the doctors had 25 cases. So the other major thing that we can work on is the informed consent, updated informed consent. That will actually be a major thing that we can do. This is actually the details page I included in your packet, and there's actually even more detail to this that is available also if you would like it.
Yeah.
And
you can find that online. It's all public.
and
Okay, just make a statement, yeah. I think the goal, what we were trying to achieve and why I kind of made Gail and Run to do this was, we just need another way to slice the pie. We know we had additional issues we needed to address. It's just another tool, another way to measure how we are, the quality of the care we provide throughout. And so that was the goal behind this.
and
We knew the grade would be there, so we have areas of opportunity. This just lays it out and gives us kind of a work plan.
And it's actually already helped us in one area. You saw all those medication errors and things. The one thing that Leapfrog wanted us to do is barcode medication administration process. Almost anything to do with medication administration falls underneath this category. They wanted us to have like our own little committee and workforce on it, so I created one. It's actually a subcommittee of the Patient Safety Committee, but it also is kind of like a subcommittee of the Pharmacy and Therapeutics Committee also. So through this Leapfrog, I discovered that our barcode scanning rates don't even measure anything in PACU. They don't pick up anything in our recovery room. And it's been like that since it got started, like in 2015. So we're gonna have to try to work on that. The other thing is most of the, like, in the lower category of the medication errors, not like 9 of them are related to barcode medication scanning. There should be different alerts to let us know to try to make medication administration safer. So we're just digging deeper, and this is exactly what we're gonna help with.
And through the chair, I have to say, I wanted to do this survey since I have been in this role. And in order to do the survey, you have to get your approval and sign off through your CEO. So Joe has been the first CEO who has approved and had this move forward. So I have to appreciate Joe for saying yes and having us do this, because I think this is a better measure. I appreciate CMS 5-star rating. But I think this is really getting to some patient safety issues for us to engage our staff and to work on some issues that are going to move us forward in patient safety. So I really appreciate that he said yes and gave us a really short time frame to make this happen.
Yes.
As long as we're gonna move up, right?
Absolutely.
Who wants to advertise we're gonna see?
You know, it's
Topics aren't great,
well,
but it sounds like we're gonna go up
Yeah.
and we're learning a lot.
Yeah, you have to take that
Yeah.
first step.
And safety is of course paramount
Yeah.
to a hospital.
so in Southeast Alaska, critical access hospitals cannot do Leapfrog. So I believe it will be us and Ketchikan.
Ketchikan decline.
Yeah, so it'll be us is the only hospital.
Either good or bad if you're, it's bad if you're a D and it's good if you're an A.
Yeah.
So it doesn't matter if we're the only one. The grade is what really matters to me.
Mm-hmm.
Do you know how many hospitals in Alaska do it?
I think 9.
Yeah. Yeah. But we will always be on anyway. I mean, Leapfrog's gonna give us a grade based on our CMS reporting, so we're
And
always gonna be there.
TMC is like a C. Providence is a C. Massey was a A. Soldotna. Actually, Soldotna did not.
A couple of years ago, we had a B for 1 year. We were a B.
I think anything that's improving safety to the patients is worthwhile.
And we've had engagement. That's the other thing. It's things that staff can be engaged on and work on, like medication, administration and scanning. I think we've had more staff engaged on what is frustrations and the things that are making it difficult for them to do barcode scanning. And we've had fixes already and some wins for them.
Any questions From the front. Do you, any questions, comments from the committee? I just want to say thank you for all of your guys' hard work. Compliance and quality is not always, what do I want to say, a really rewarding thing at times. So it's all perseverance and getting it done. So thank you guys. Thank you. The job everyone wants to do.
Sexy.
It all depends on